My name is Hasti and I'll be moderating the webinar today. With all of our public webinars, I have to add the following disclaimer that you will now see on the screen. So this webinar is only for educational purposes as it provides general information and should not be taken as medical advice. So I would first like to speak a little bit about MIHCAN. Maternal and Infant Health Canada, also known as MIHCAN, is comprised of doctors, researchers, and traditional medical practitioners from Canada, India, and around the world. At MIHCAN, we aim to work closely with local healthcare workers, traditional medicine providers, governments, and community members to improve maternal and infant well-being and reduce maternal and infant mortality in both India and globally. MIHCAN recognizes that the only way to make a true lasting impact is to look at all of the determinants of maternal and infant health. So this webinar today is regarding MIHCAN's goal to educate others about their health as we discuss low back pain in pregnancy and how to assess, diagnose, and treat it in 5 minutes or less. Our speaker is Dr. Alain Bertrand, a 1965 graduate of McGill University Medical School. Dr. Bertrand has been in family practice since 1966. Having suffered 37 years of low back pain following her first pregnancy, which was cured with prolotherapy, Dr. Bertrand published a research project on prolotherapy and since 2010 has limited her practice to the treatment of severe chronic pain. Through her research, Dr. Bertrand and her pharmacist colleague have developed a pain-relieving cream called QR cream. Dr. Bertrand has also developed a new way to examine and treat cases of low back pain. Okay, so let us get to the lecture. Please welcome Dr. Bertrand.
What I want to talk about is a new way to diagnose and treat low back pain. And the reason I want to talk about it is that I can tell you how awful this condition is. When I was pregnant, I had excruciating pain. And after my baby was born, I remember trying to go up the stairs with essentially carrying my baby on my seat because I could not put one foot in front of the other to go up the stairs. And when I'm thinking of all the other mothers who suffer this, I think it's terribly important that we are able to treat them now. By the way, because of this, I've experimented on different ways in treating this. Because I'm interested in treating severe chronic pain, I've developed this cream that takes away pain, actually better than narcotics, but I am essentially not publicizing it today because I think it doesn't work very well with QR cream and with pain. And the reason it doesn't work well with low back pain is that the pain that is caused in the back is much too deep for a skin cream to deal with. Why would we spend the time to examine and treat a sacroiliac joint? After all, it's easy. If somebody comes in and says, I have pain in my back, you say, oh yeah, we'll get an x-ray of your back. Here, go to the physiotherapist. They'll give you some exercise. Don't spend your time in bed. It's not good. Get back to work as soon as possible. You give them painkillers. And then they leave your office, and they leave your office in as much pain as when they came in. What have you done for them? Well, I developed this new way to examine and treat the back because I felt that there was, if you look at statistics, you'll find that 84% of all severe low back pain is considered to be idiopathic. We don't know. And so I figured that there had to be some way of knowing the cause of this pain. So I invented a way to examine the sacroiliac joints because a lot of people don't point to their lumbar spine and don't have sciatica when they have pain in their low back. They have pain in their butt. And this is why I started to examine that area particularly. I did a chart review, which I presented at the Canadian Pain Society, on 180 patients who had been diagnosed with low back pain. They either had lumbar spondylosis, lumbar disc herniation, sciatica, or sacroiliac sprain. They were between 20 and 90 years old, on average 62 years old. There were 106 women, 58 men, and they had been in pain on average for 3 years. Now, I found that in those 180 cases, I only found 16 cases, which could be called lumbar spondylosis or disc herniation or sciatica. A lot more people had abnormal x-rays, which showed spondylosis, facet joint arthropathy, disc herniation, but they didn't have pain going down their sciatic nerves. They didn't have pain in their lumbar spine. 164 of these people had pain at the level of their sacroiliac joints. And some of them I diagnosed as piriformis syndrome, but piriformis syndrome is simply a symptom of sacroiliac instability. So when should you examine the sacroiliac joint? If somebody comes to you and they have pain in their butt, for sure you're going to examine the sacroiliac joint. But unstable sacroiliac joints also cause pain in other muscles. And you will also often have pain at the level of the quadratus lumborum here, because the quadratus lumborum is a stabilizer of the sacroiliac joint. So this is one of them that you have to examine when somebody comes to you with low back pain. You have to have a look at their sacroiliac joint. Now, what symptoms will somebody give you when they have pain in their sacroiliac joint? They'll say, oh my God, it hurts to walk, it hurts to run, it hurts to climb stairs. Why? That joint is a major shock absorber for your spine. It protects your spine from shock. And so the shock of every step is going to displace that sacroiliac joint. No wonder it hurts when you're walking, running, or going upstairs. You also sit on your innominate bone. Hey, your innominate bone is part of your sacroiliac joint. And so people who have sacroiliac joint pain will often have pain when they're sitting or getting up from a sitting position. The other reason they get up, they have pain on sitting, is they always develop tendinitis of the biceps femoris and the semitendinosus and semimembranosus muscles, which attach on the ischium where people sit. So people with sacroiliac joint pain have pain there. Now, these are the muscles involved in stabilizing your sacroiliac joints, okay? First of all, you have the piriformis. And the piriformis attaches on the sacrum and the greater trochanter, and you get piriformis syndrome. Well, piriformis syndrome is just a manifestation of sacroiliac joint instability. You also have the gluteus minimus and the gluteus medius, and these attach on the ilium and the greater trochanter, and they are also involved when the sacroiliac joint is unstable. And you'll get patients who are diagnosed as having trochanteric bursitis. Well, no, they have trochanteric bursitis because they have a tendinitis of their gluteus medius and minimus, unfortunately. Okay. The quadratus lumborum inserts on the 12th rib every single lateral process of the lumbar spine, as well as the ilium. And it is another stabilizer of the sacroiliac joint. All these muscles that attach on the ilium stabilize that joint. Okay, so when you walk, when you stand, when you roll over in bed, every time you're doing this, you're straining your quadratus lumborum, and you will have pain if your sacroiliac joint is unstable. Now, in front of the sacroiliac joint, you have the iliopsoas. The iliacus muscle is attached to the front of the ilium and to the lesser trochanter. And people who have pain from their unstable sacroiliac joint will often have pain at the insertion of the iliacus muscle on the lesser trochanter. They also have pain when they're lifting up their legs, which is what that muscle does. Now, you've heard of neuralgia paresthetica, and it's always considered to be, idiopathic. Well, it's not idiopathic at all. You've got the lateral femoral cutaneous nerve, which is inserting on the inguinal ligament. And that inguinal ligament, essentially, you see where the nerve inserts on the inguinal ligament? It's right in front of the right ASIS. Okay, that nerve goes down the leg and goes all the way to the side of the thigh. And people with neuralgia paresthetica, and by the way, I saw 2 of them today in my office who came with sacroiliac instability and loss of sensation and a burning sensation on the sides of their thighs. They had neuralgia paresthetica from sacroiliac instability. Now, because I'm trying to move this, it's not moving. How do I get it to move forward? Maybe I'll make it smaller. That's it. Okay. Now, the SI joint has a bunch of ligaments that stabilize it. If you look at your sacroiliac joint, you have more ligaments stabilizing that joint than any other joint in the body. Look at the difference between the ligaments stabilizing the hip joint with those stabilizing the sacroiliac joints. And when the sacroiliac joint ligaments fail, that is when you get displacement of that joint, and that's when you get tendinitis of all those sacroiliac stabilizers. Now, what conditions will weaken the ligaments of the sacroiliac joints and cause a sprain? Okay, those are conditions where you have weakened ligament, weakened collagen. And the first condition that is going to weaken that collagen is pregnancy. You produce relaxin so that the pelvis will be able to accommodate the baby's head during birth. And because of this hormone, the sacroiliac joints become unstable. Huge numbers of pregnant women will develop low back pain, and we have to be able to diagnose it and to tell them how to fix it. Old age will do it because you lose collagen with old age. Remember, when we get old, our skin loses its collagen and we get wrinkles? Well, the ligaments also lose their collagen and they lose their ability to stabilize joints. That's why we get arthritis. Injury. A lot of people will have sacroiliac joint pain because they've had a fall on their buttock, or they've been rear-ended in a car accident and their foot was on the brake. And when the foot is on the brake, the force of the blow goes right up to the hip joint, which then pushes on the sacroiliac joint, which then sprains the ligaments holding that joint. People who have a leg length discrepancy will often have problems with their sacroiliac joints because there's much more pressure on one joint than on the other. And of course, a lot of people are hypermobile. 15% of all the people that I treated when I was doing this chart review were hypermobile. So these people will have loose sacroiliac joints. So now I'd like to have a video of the sacroiliac joint, and I'd like to show you how I examine and how I treat sacroiliac joints. This is your sacroiliac joint. This is where the ilium meets the sacrum. And every step you take moves the sacroiliac joint. It is your body's main shock absorber. It protects your spine from the shock of every step you take. You're feeling for a sacroiliac joint, you're feeling these bulges on the bone, called the posterior superior iliac spines. When one of them is higher than the other, it means that the bone has tilted forward. If the painful one is lower than the other, it means the bone is tilted backwards. Here's your patient. He's standing with his legs pushing up on his iliac bones and his pelvis tilted forward. This allows you to feel his PSISs much more easily. Now, I want to feel exactly where these PSISs are starting because I want to know exactly in what position these iliac bones are. So I'm going to try and feel them. Now, I don't want to feel them with the flats of my thumbs, because if I use the flats of my thumbs, they just glide on the back of the PSISs, and there's no way I can tell exactly where the PSIS starts. But if I use the sides of my thumbs, and I put them like this, and I advance them, when they reach the PSISs, they come to a dead stop, and then they flip up. So I know where the PSISs are exactly when my thumbs come to a dead stop. It's at that point that I put a fingernail mark on either side. And then, once I've got the fingernail mark, I'm going to use a marker, and I will mark exactly where the PSISs are. This is the perfect position to examine somebody's sacroiliac joint. The legs are vertical, the body is horizontal. And that way you can see how the ilium is bent forward and how the thighs are pushing up on the ilium. So when you come to examine this patient, you have to put your thumbs along the iliac crest and you follow them down until you feel where your thumb is going to hit on the PSIS, right here. And then you take a skin marker and you mark it. Okay, and again here, you use your thumb and you feel along the PSIS. Can you tell me where you're tender? Is that tender here? Show me exactly. It's higher up. So you're tender here. Okay, but your PSIS that I'm looking for. Oh, wait a second. Wait, here it is.
Yes.
There, here it is. That's where she's tender. So we put a marker here, and now we can see that the levels of the two PSISs are very different. I wonder if you can stand up. Just stand up. And now I'm going to use a level. And I'm going to mark the exact spot, the exact level of her PS. So the lowest one is on the left and the highest one is on the right. And I'm going to mark the difference between the two levels. Now I'm going to take a ruler and I'm going to see what distance there is between the PSISs, and it turns out that there are 2.5 centimeters between the lower one and the higher one. So I put a B here for before and a B here for before. Which side is sore, by the way? Which is hurting?
Left.
Just the left. Okay. So we know that her left PSIS is very much tilted backwards, posteriorly. And so what we need to do now is we need to stretch the anterior part of her left thigh to pull on the ilium to bring this innominate bone anteriorly. So can you pull up your pants, please? Okay. Now, because her left ilium was tilted backwards, she is going to use her left thigh to pull on the left ilium by stretching her left thigh as much as she can. And she will hold this stretch as hard and as much as she can for the next 2 minutes. Find out whether these 2 minutes of exercise have actually helped anything. And remember that this is where the posterior superior iliac spine was before. It is. It's not here anymore. That's good. But where? Oh, wait a second. Here it is. Okay. Her left posterior superior iliac spine is here. This is before with the letter B, and this here is after with the letter A. Now let's see where the right one is. Oh, it's perfect. It stayed exactly where it was. Okay, so now let's check the level. Can you make yourself upright, please? And let's see if the level now. This is after, and this is perfect. Perfect. Okay, that's it. She's corrected her back. Still have pain in your back?
No, it's gone.
Even when I touched it?
Even when you touched it.
Good. Right here. Now let's see where the left PSIS is. And this is not a PSIS, by the way, this is a mouse. That's what's sore? Right here? Yeah. Okay. Oh, okay. B here for before. And then we will use the level. Stand up.
Stand up straight.
Just stand up nice and straight. So we'll see together. Yeah. And we'll see with the level. Okay. So can I have a marker, please? We'll have a marker here. And now let's measure what the distance is between the PSISs. So there's 1.5 centimeter distance between this one and this one. And this one is 1.5 centimeters higher than this one. So what you need to do is you need to bend your knee until it touches the chair and put your foot on the middle of the chair. Now lean back, lean back. Feel how your thigh goes up against this bone here when you're leaning back, and now pull up as hard as you can, as hard as you can. Just keep pulling, because what you're trying to do is you're driving this thigh into your pelvis, okay? And drive it as hard as you can, because you want to force this bone backwards. You see, if you force the bone backwards, then you'll be able to put it back where it belongs, okay? So, and now you need to hold it for 2 solid minutes. That's the mouse. But is this still hurting? No. Because this is where she's at now. That hurts now, but look, this is where she's at now. Let's see if she's level. Let's see if she's level. There she is. She's level. Mm-hmm. She's fixed her own back. Is I'm going to stretch this thigh because what's happened is your pelvis has gone back like this. So I'm going to pull on your thigh to bring it forward, okay? Now this one has gone forward, so I'm going to push your thigh against your bone here to push it backwards, okay? What I'm doing is I'm putting your pelvis back where it belongs, okay? On the very edge, and okay, that's it. And now bring your leg up like this, and now lie back, lie back, lie back, lie back. Okay, that's it. Now I'm going to put your foot on my chest here, on my sternum, and then I'm going to lean forward hard to push this bone again. You see, I'm pushing your thigh against your ASIS, okay? Very hard on this bone here to pull that ilium to the front, okay? And I'm pushing very hard on this one to push that thigh against your ASIS. And we're going to hold this for 2 solid minutes.
Okay, and so.
Okay, that's it. 4, this is a B, and this is a B. This is where she was before, and there was 2 centimeters between these. So now let's see if she has changed, okay? So let's see, is she still, no, she isn't. Ah, here she is, right here. Okay, so the left one is here, and this is A, that's after. Now where is the right one? Ah, the right one is here, and so this is after. And now let's see if she's level. Can you stand up, please? And let's see if she is level. Ha. Well, she is perfectly level. Okay. Nice. Now she's level. Okay, good.
Definitely better. Definitely feels, I don't know, I guess more even in some way. It's weird. I haven't felt it so long, I don't know how to explain it. Okay, enough, I have noticed too that it's a little bit easier for me to keep my shoulders up, which normally is a very difficult position for me. I always want to peer down.
Yeah. Pelvis, you know, the ones that stick out? Okay, so let's see if you're level when we put the level underneath those two little fingers. Are you level? Yes, you are. Yes. Perfectly level. And that's because you're straightening out your back. But first of all, do this. And that allows you to watch. I'm going to put it here and around your body. And where are the two little bones that were sticking out? They're right here. You can feel the two little bones that stick out right here. Okay? Put your fingers on the two sticky outy bones, okay? Because this is where you want to put the belt, just below the sticky outy bones, okay? The thing is that you want to hold this part of your pelvis in place. You do not want to open up those joints. If you put your belt here, you're opening up the joints. That would be totally counterproductive because then the joints can really go out. What you want is you want to make sure that those joints are well held together. So your belt is going to go right here, like so and like so. Now, get the two little bows and pull on them really hard. So yeah, put it as far forward as you can. That's good. That's it. There. Yeah, that's it. Now, do something that would hurt your back. Is it hurting now? No. That's the name of the game. You can bend over as much as you want because your pelvis is being held in place.
When I get up, I feel the most pain, but this time I did not feel any pain.
Essentially, now you know exactly how to examine a low back pain. Once the pain is relieved, you see, okay? So here we go. So essentially, you just saw the patient doing the chair exercise. I did that in 96 of the people, the 164 people I treated who had low back pain, because they had an anterior sprain of their ilium on the sacrum. And of those 96, 49 or half of them had complete pain relief, and 31% had partial pain relief, which means that 82% of those with severe low back pain ended up after a 2-minute exercise with little or no pain. This is something that is extremely satisfying. I assure you, your patients are very grateful when that happens. Now, if those who did the thigh extension exercise for posterior sprain, 84 of them had a posterior sprain and were given that thigh extension exercise. And 43 of them, 52%, had complete pain relief, and 20 had partial pain relief, which means that 76% of those with a posterior sprain also ended up with almost little or no pain at all before they left my office. So once the pain is relieved, you've got a patient who knows how to treat a recurrence of their pain because they know now what exercise to do. Um, if there are too many recurrences, then of course they have a very unstable sacroiliac joint. And then I prescribe a Sorolla belt to stabilize the joint. I know in India, the Sorolla belts are not easy to find and they're quite expensive. But if you just tie something very tight underneath the ASISs, you get the same results. You need to have something very tight to hold those sacroiliac joints together. And if that doesn't work, then you need to do prolotherapy, and that's another lecture. So why spend the time to examine and treat the sacroiliac joint? Well, of those 180 people who I examined and treated, 50% had complete pain relief and 28% had partial pain relief. And that suggests that at least 50% of all those who have severe low back pain actually have pain in their sacroiliac joints. And you can relieve that pain quite easily after a 2-minute exercise. So essentially, all you need is about 5 minutes to examine your patient and to treat them. And I assure you, it's very, very satisfying. It'll cut down on the number of x-rays and MRIs and CT scans you take. It'll cut down on the need to consult other people. It'll cut down on the need for expensive physiotherapy and chiropractic manipulations. And it will cut down on the need for anti-inflammatory medications and narcotics. It's an easy way to help your patients and very, very satisfying. Now, of course, the study was very limited because I was the only one who was doing the study. And most of the patients that I had failed numerous other treatments. The chart review that I did was retrospective. There's no follow-up data, no randomized controls. So it's a very limited study. And this is why right now I'm conducting a randomized study. And I'm hoping that some of you will be interested in joining this study, and maybe we can enlarge it so that more people can do it. Essentially, I'm asking people to get their patients to respond to a brief pain inventory and to fill out the ODI, the Oswestry Disability Questionnaire, so I get a good measure of low back pain. And they're given essentially an exercise, either the back exercises or the belt, or essentially they wait a month and then they are treated with both the exercise and the belt. And if some of you want to try this, I would really welcome your contribution. Are there any questions to what I just said?
All right, perfect. So thank you, Dr. Bertrand, for your engaging and informative lecture. So we can now get to the viewers' questions for the next 10 minutes or so.
No questions.
Oh, I think they're just coming up now. Yeah, okay, there we go. So the first question is, can you explain how people can have good health in the iliopsoas? It seems that this very deep muscle is tight in most people, especially because of sitting.
Yeah, that's true that the iliopsoas is tight because a lot of people are spending most of their lives sitting right now. But the iliopsoas is only going to hurt when the sacroiliac joint is under stress, because that iliopsoas is working to stabilize that joint. So I suspect that the iliopsoas is able to stand a lot of sitting, but it can't stand the fact that it has to hold that joint when it's unstable. And so I don't think it's a question of good health in the iliopsoas. I think it's a question of how tendonitis develops when the sacroiliac joint is unstable. What are the particularities of lower back pain diagnosis for pregnant women? Specifically, are there any risks to the baby in doing these exercises? What's nice about the exercises is that you're not actually putting some pressure on the uterus. You're putting pressure on the iliac bones, which are not directly in the center of the abdomen, they're on either side. So if you're pushing your thigh against the iliac bone, you're pushing against the ASIS, you're not pushing on the uterus. And furthermore, the baby is sitting in a bath of water. And if you start pushing on one ASIS, the baby will deviate to the other side and there won't be any problem for the baby. There could be a question about the Cirola belt or a belt that's very tight across the pelvis. But again, the Cirola belt is holding the pelvis at the level of below the ASISs and below the PSISs. So it's just holding the pelvis at the level of the sacroiliac joint, and therefore it does not interfere with the volume of the abdomen. Do most people have leg length discrepancies, and what can patients do about this? A lot of people have leg length discrepancies. I'd say maybe 1 out of 3 of the patients that I examine have slight leg length discrepancies, like 0.5 centimeter, 1 centimeter. And for those patients, I give them, what I do is I use some Kleenex and some duct tape. And I take some Kleenex, here's some Kleenex, and I fold it like this, like that, like that, and like that. And I fold several pieces of Kleenex like that to make a lift, which you can put, if there is, say, 0.5 centimeter of leg length discrepancy or 3/4 of a centimeter, you can actually put it inside the shoe and you hold it with duct tape. Or you can put, or inside the sandal and hold it with duct tape. Or you can put it, if there's more than a centimeter, you make a centimeter lift, and you put some duct tape and you put it underneath the heel of the shoe, and you can lift up the legs to equalize them. Why is 84% of low back pain idiopathic? That's a very good question. You'll notice that most joints are nice and regular. You know, the hip joint, it's a nice ball and socket joint. The facet joints, they're nice straight joints. The knee joints, they're nice and straight. They're easy to visualize. Well, the problem with the sacroiliac joints is that, first of all, their orientation is very, very variable. And secondly, they're shaped like this. They're not shaped like a nice regular joint. They're very, very irregular. And because of that, it's impossible using X-rays, CT scans, or MRIs. You can't see these joints using the usual medical imaging techniques. This is why it's so important to learn how to examine the joint and how to know when the joint is too far forward or too far backwards. Why hasn't medicine advanced further to be more precise with diagnoses? Precisely because we are increasingly relying on medical imaging. And as I'm telling you, medical imaging cannot diagnose. The only time medical imaging is helpful for sacroiliac joints is if you've got ankylosing spondylitis. And this is not what most people have. Most people have a slippage of these joints, and that slippage can't be seen because of the irregularity and the poor orientation of these joints. If you want to visualize these sacroiliac joints, you have to take cuts in the direction of the joint. It's very difficult. Do you encourage patients to do these low back pain diagnoses and exercises without supervision? Well, of course. When my patients leave my office, they do it without supervision. Now, there is a problem. Some people are so very hypermobile that when they straighten out one joint, they've actually pushed it too far ahead or too far behind. And in those very hypermobile people, I say, well, if it hurts on the other side, then do the exercise on the other side. It's that simple. Um, do you encourage patients to do, sorry, um, eventually you envision that all people with just a carpenter's leveler tool and a friend will be able to diagnose their lower back pain and then eliminate back pain? Yes, I think most people will be able to do it. The people who won't be able to do it are people who have tears in their sacroiliac ligaments or who are hypermobile, because these people will constantly have to um, straighten out their joints, and they will constantly have to uh, have something to stabilize the joint, like a Cirola belt or a very, very tight piece of material tied around the lower the lower pelvis. Um, Now, I think eventually those that have uncontrollable hypermobility will have to have prolotherapy, but you can fix things with prolotherapy quite easily. Um, okay, are you all aware of prolotherapy? Um, when I'm doing prolotherapy, I'm essentially doing a series of injections where the bloodless ligaments and tendons, remember they're white, attach on the very blood-rich periosteum, because that's where all your blood cells are made. So there's lots of blood vessels in the periosteum. You create a small injury there, and I use 25% dextrose injections in those areas. If you create a small injury there, you are actually causing inflammation. You grow new blood vessels into those bloodless ligaments. The new blood vessels bring in the repair cells. The the and these repair cells will deposit collagen, and scar tissue is collagen. But ligaments and tendons are pure collagen. So you can fix ligaments and tendons with prolotherapy. Um, how can we be a part of this study? We're a group of physicians from a medical college from the southern part of India. We have a network of rural and urban health centers. So kindly let us know if it is feasible to be part of the study. I would love to have you part of this study. And what would need to be done is, first of all, you're going to have, I need to have ethics approval for that. And to get ethics approval for you guys to have part of the study, you have to have approval from your university ethics center. And if you do have that approval, then I will tell you exactly how to do it. And it's okay, it's a little bit complicated. You're going to need, like you would need to have your patients enter the questionnaires, uh, sign the consent forms, and all of the other things. If you have cell phones, or if you have um, tablets, then you can do the questionnaires on the tablets, and they can go directly to our center. So it's not really impossible for you to do it. And but if you're interested, then just contact me on my email, and I'll give you the information. I am a physiotherapist, would like to assist in the studies related to pregnancy and post-pregnancy. I would be delighted if you wanted to assist, and anytime you can come and see me in my office. I'm currently doing this study, and I'm seeing maybe 3 or 4 new patients every day. And if you're living in Vancouver, that would be delightful. I would love to have somebody come in and do the study with me. Is that all the questions? Okay, so I seem to have answered all the questions. And I hope that you guys have learned something today. Um, I'm thinking that this new way of examining and treating patients who have low back pain will change the way low back pain is seen. I mean, like 84% of all low back pain is most likely coming from the sacroiliac joints. And things like trochanteric bursitis, they are tendinitis of these sacroiliac joint tendon stabilizers. Things like um, neuralgia paresthetica, it's just a neuropathy of the lateral femoral cutaneous nerve when it's trapped by this displaced ilium. Things like um, what is it called? Piriformis syndrome. Same thing. It's a tendinitis because of sacroiliac instability. All of these misdiagnoses that are made. People talk about lumbar pain when in fact the chances are it's their quadratus lumborum that's complaining. So most lumbar pain, most low back pain is due to the sacroiliac joint. And I'm hoping that all of you will have the opportunity to find out by examining your patients. And I think you'll see that you can fix them quite easily. That's it.
Okay. Thank you, Dr. Bertrand, for answering those questions. And I was just seeing that there's actually a couple more questions I think maybe we'll have time for. There was one question asking about your future studies.
Well, I'm an old lady, and what I would like is if somebody else took up the baton and did a future study. For instance, a future study on pregnant women would be extremely important because I think low back pain in pregnancy can be very incapacitating, and not just incapacitating for a short time. I had 37 years of severe low back pain following my pregnancy. And this is, for very many women, it prevents them from working. Um, why don't all medical schools teach patients to diagnose and treat their health problems like this? Um, I am unusual as a physician in Canada, and the reason um, medical schools don't do that is that they've become increasingly reliant. Instead of physicians using their fingers and their brains and their eyes and their ears to diagnose patients, they're sent for lab analyses and medical imaging. And so there's a huge emphasis on pharmacology, laboratory diagnosis, and medical imaging. There is no emphasis on a knowledge of anatomy, a knowledge of your cutaneous nerves, a knowledge of how to use your fingers to examine people. Because using your fingers, you can make a diagnosis, at least in my case, at least 90% of the time. And I think it's a great failure of our medical schools that they do not emphasize that.
Okay, so I believe that was our last question. Thank you so much for your questions. And if there are more questions later on, feel free to visit the MIHCAN website at maa.med.ubc.ca. Is there anything else you would like to share with our viewers before we end the webinar, Dr. Bertrand?
Um, all I can tell you is that treating severe chronic pain is now the most rewarding. I've practiced medicine now for almost 56 years, and I have to tell you that the most rewarding part of my whole lifelong medical practice has been in treating severe chronic pain using um, prolotherapy, using manipulation, teaching people exercise, corrective exercises, teaching patients how to fix themselves, and using nerve blocks. And the reason I discovered this cream that I invented was because I was doing nerve blocks using 5% dextrose right near nerves. And by the way, obstetricians should try 5% dextrose buffered with a little bit of soda bicarb for pain in labor and delivery, because you can, if you put the 5% dextrose in the low back where people normally put saline, you'll find that the pain will go away much longer and much better than with saline. But I was using 5% dextrose for peripheral neuropathy, and I found out that a lot of diabetics had peripheral neuropathy. So I switched to 5% mannitol, which is a dextrose molecule with one OH added to it. And when I put in the 5% mannitol, the pain disappeared. And by the time before the needle is out of the skin, the pain is gone. So I got together with this pharmacist and I made this cream. And the cream contains 30% mannitol, and now I've commercialized it. So, but I don't want to advertise that. But it is exceedingly effective. So it's exceedingly effective.
Great. Thank you again. And thanks for our viewers for joining our webinar and asking questions. Again, feel free to visit our MIHCAN website. And also our Facebook page is right up there. It's under Maternal Infant Health Canada. And you can find out about any upcoming webinars on there as well. Lastly, thank you to Healthy Seminars and MIHCAN for organizing this today. And we look forward to doing this again.